Good afternoon. Welcome to this fourth international webinar organized by Vets and Clinics by Advance. My name is Alba Martos. I'm International Vet Manager of Affinity. And today I'm very happy to be here with Alejandra. Good afternoon, Alejandra.
Good afternoon.
Alejandra is an European diplomate in Anesthesia and Analgesia. And nowadays she's the head of the Department of Anaesthesia and Analgesia at the Veterinary Hospital in the University of Valencia. So today we have the opportunity to have her here, and I encourage you to ask her anything you consider. You know that at the end of the session, we will answer the questions, but remember that in case we do not have enough time, do you have an email below where you can send your questions, and Alejandra will answer all of them. Also, before starting, I would like to remind you that you can download the presentation clicking on the link you can see in the screen below. And well, I think that this is all. I will not delay any longer, and we'll start the session. Alejandra today, she will talk about how we can adapt our anesthetic and analgesic protocols to obese and cachectic patients. So I think, Alejandra, that for introduce this session, it would be nice if you can share with us why do you think that it's important to share this topic with our audience.
Perfect. Thank you very much, Alba. And I would like to take this opportunity to thank, first of all, Vets and Clinics by Advance for having me here today to talk about this topic that is more and more common in our pets recently. So how should we anesthetize patients with cachexia or obesity? So the first things that we need to see is that body condition reflects the patient's state of health. Basically, if we see that obesity in small animals can vary from 1.8 to 10% of patients, this is meaning obesity as a clinical condition, meaning patients with diseases. However, the prevalence of overweight patients can reach up to 45% of the population in small animals. Therefore, it's really common that we will have to have these patients for anesthesia or sedation to do diagnostic procedures or surgical procedures, and we are going to have these patients coming in. Therefore, we need to estimate, first of all, the body fat that we have. And in here you have some examples about the body condition score that we use clinically for dogs and for cats. And we see here that one is very, very thin, then we have thin, ideal weight, overweight, and obese. And in the in the right-hand side, you have the DEXA, which is kind of an X-ray that gives you the amount of fat that the patient has at the moment of taking this image. So the methods for estimating the percentage of body fat, we have the clinical ones that are the body condition score, and the research methods, which will be the DEXA. So
Alejandra, how, I mean, now that we know that the body condition is really important, how it can affect our anesthetic protocol?
So here you have the picture of the American Society of Anesthesiologists, or very well known as ASA. And you know the ASA is a risk, basically risk ratio that we have to estimate the risk during anesthesia in our patients. So the body condition and the anesthetic risk are related. Some adverse changes in body condition can basically reduce the patient's life expectancy, reducing the lifespan of the patient, increases the incidence of comorbidities such as diabetes, cardiovascular disease, pancreatitis, mammary tumors, kidney disease, among other problems that we can have with the increase in body condition. So, focusing on anesthesia, we have an increased anesthetic morbidity and mortality in extremes of weight, meaning in cachectic animals and obese patients. And this is the article that you can find this information. The increase in ASA classification of anesthetic risk is obviously a bad thing. And in cats, weighing more than 6 kilos, these cats were 3 times more likely to experience complications than cats weighing between 2 and 6 kilos. And this is also the same reference. So you can see in extremes of weight, we have higher anesthetic risk. So let's talk about cachexia, which is an extremely thin animal with exaggerated weight loss, including muscle mass, due normally to a chronic disease. Unlike cases of starvation, in cachexia, there is a marked activation of the inflammatory response with excessive production of inflammatory cytokines and increased energy consumption at rest. So, for diagnosis of the cause of cachexia, there are different diagnoses that we can take into account. The first of all is starvation or malnutrition, so poor dietary management, not only poor quality of the food, but also restricted access, also competition within a group of animals. So the other animals are aggressive to one, and this one is not able to eat properly. Other causes are oral cavity diseases, gingivitis or gingivostomatitis in cats, mouth ulcers because of renal disease, dental problems, for example. And then in the gastrointestinal system, basically chronic inflammation or infection in the intestinal or blood parasites, immune diseases that affect the gastrointestinal system and is not able to get the nutrients for our patients. And then poor digestion, malabsorption, diabetes mellitus, nephropathies or protein-losing enteropathy or nephropathy, and cardiomyopathy. And then elevated metabolism like hyperthyroidism in cats or chronic fever, and lately neoplasia. In the picture that you have here, we had a dog with a tumor in the stomach, and that was the cause of his cachexia. Basically, he had chronic vomiting, neoplasia, and obviously he was presented with cachexia to our clinic. The anesthetic considerations for cachexia have to also include the underlying disease. Not only that my animal is very thin and cachectic, but also we need to look for the underlying disease that is causing this. Basically, we have to check for patients with renal failure, hyperthyroidism, heart disease, and all the causes that we have spoken about. So it's really, really important to have a complete pre-anesthetic assessment, including complementary tests needed to diagnose the causes of this adverse change in the body condition. So the pre-anesthetic assessment is really important that is complete.
Thanks, Alejandra. So now that we have seen the main considerations with cachexia, let's continue with this cachexia. What are the anesthetic considerations that we have to take into account with this kind of animals?
So depends a little bit on the pre-anesthetic assessment that we have done, which normally we have included hematology, biochemistry, plus minus diagnostic imaging in each case, depending, of course, of the status of the patient. So it's difficult to assess the hydration status in these patients because of the lack of subcutaneous tissue and the loss of muscle mass. Therefore, for example, the skin tension test for hydration status is difficult. Other metabolic abnormalities can be present, so we need to check in our pre-anesthetic assessment the glucose level, so the glycemia. We need to detect and correct before anesthesia if there is any problem with the glucose. Thin patients also are more prone to hypothermia because they have less thermal insulation due to the loss of subcutaneous tissue and the muscle mass as well. And depends in the liver function tests. If the liver function is increased or decreased, can change a little bit our anesthetic protocol. And also this liver function will be increased or decreased depending on the etiology of the cachexia. Hypoalbuminemia is common in cachectic patients. Normally it's a decrease on this albumin, causes a decrease in the oncotic pressure, and we can even get ventral edema, ascites, and other problems related with the hypoalbuminemia. Other problems that we can get with the hypoalbuminemia is the monitoring the blood pressure is really important, because we may need to use colloids, albumin, or fresh frozen plasma transfusions if the albumin is below 1.5. This is obviously in severe cases.
So, well, now I think that we can move on to the drugs. So, how, Alejandra, can you explain how these cachexia affect the pharmacokinetics of the anesthetics that we are using in these animals?
Very good. So the changes in the pharmacokinetics, let's speak about a little bit of the definition. So basically, pharmacokinetic is the relationship between the dose administered of any drug and the plasma concentration of this drug. So it will give us, we normally divide the pharmacokinetics in absorption, distribution, metabolism, and elimination. The importance of the pharmacokinetic parameters that we need to basically know is first the volume of distribution, the clearance, the half-life, the elimination half-life, and the context-sensitive half-life. So the volume of distribution, if you see in the picture here, the diagram, is the volume in which the dose of a drug distributes in the body. Then we have the clearance, which is how quickly the body will basically clear the drug from our system, from our patient. The half-life is the life that this drug has, and obviously will be influenced by the volume of distribution and the clearance. We have the elimination half-life, so it's how long will it take to be eliminated, and the context-sensitive half-life is how long will it be eliminated when I have a constant rate infusion. When I stop the constant rate infusion, how long will it take to be eliminated from the body of my patient? So, talking about the volume of distribution in these patients, because of cachexia, the volume of distribution is important to know that the drug will be distributed after this initial bolus, and the dose that we are going to give versus the plasma concentration will be individually variation between the weight, the species, the water to kilogram ratio. As you can see here, we have a problem with our cachectic patients or our obese patients as well. So we will have different plasma volume, interstitial volume, and intracellular volume in a patient with cachexia. So the volume of distribution is important, calculating the initial loading dose. So this will be basically altered in patients with obesity and cachexia. And also it will depend on the molecular weight of the drug protein binding. So if we have hypoalbuminemia, the drug protein binding will also be altered. We have also the liposolubility of the drug and the hydrosolubility of the drug. So in cachectic animals, due to the loss of muscle tissue, the less body fat, and the redistribution of the body water, we will have a decrease in intracellular water but increase in interstitial water, meaning that we will have less volume of distribution. Therefore, our loading dose may be different. The hypoalbuminemia also influences this, as we have seen previously, that can influence the volume of distribution. Therefore, we have free fraction of the drug, because of high protein binding drugs will basically not bind to the drug, and the drug will be free to act everywhere. Therefore, we can get high peak concentrations when we give a bolus, and we can cause overdosing. And also we will have increased elimination rate, because it will change the duration of action of the drug due to the hypoalbuminemia, more free drug everywhere. Therefore, we will have possibly an increased elimination rate from the kidney, so that can change the duration. So basically it will get overdosed quicker, but it will be clear faster. Also, we have mentioned before, the liver function will be increased or decreased depending on each case, on the etiology of the cachexia. So in cases of decreased liver function due to the disease, drug half-life obviously will be increased. The liver cannot metabolize properly the drug, and longer dosing intervals will be needed, or lower dietary doses as will be required if we are giving a drug during days. Furthermore, when a drug needs to be metabolized in the liver to be activated, for example, diazepam, or some of the metabolites of diazepam are active, it needs to be administered at higher doses to obtain the same concentration of an active drug because it needs the liver metabolism to be able to start working.
Thanks, Alejandra. I think that now it's clear the whole picture for cachectic animals. So let's move to obesity. How obesity can affect also this anesthetic protocol?
So obesity, of course, is the accumulation of excessive amount of adipose tissue. In small animals, a body weight of a little bit 15% higher of optimal weight is considered overweight, and if it's 30% is considered obese. There is a high prevalence in Western Europe, Australia, and in the US, and this correlates directly with the increase in human obesity as well. So we are eating more and we are giving more food or excessive food to our pets too. Causes. Basically, the obesity will be due to a primary disorder, basically too much calorie intake and not moving too much, so the calorie intake is higher than the consumption, or could be secondary to a disease. For example, insulinoma, hypothyroidism, hyperadrenocorticism, or drug administration, for example, as a side effect of corticosteroids, that it increases the hunger and polyphagia. Also, there is a predisposition in sex, females, or sex or gender. Females are more predisposed. Age, obviously, adult or middle age are most predisposed, and sterilization as well. Spayed or castrated animals are more prone to obesity, and also breed predisposition. For example, Labrador Retriever is more predisposed to have obesity than a Galgo or a Greyhound. Considerations for obese animals. So again, pre-anesthetic assessment is really important to try to diagnose the etiology of the disease, but also obesity makes clinical examination difficult. Sometimes cardiac auscultation is quite difficult. If we have a big sized dog or giant dog, fat dog, it's difficult to auscultate properly the heart. Abdominal palpation as well, especially, as I said, in bigger sized patients. The changes on the pharmacokinetics of anesthetic agents will be totally the opposite of the cachectic patients. Cardiorespiratory physiology of obese patients will be altered, and this complicates a little bit more the anesthesia. And there are also diseases related, concomitant or secondary to the obesity.
Thanks, Alejandra. So now we have the first idea about the obesity, but I'm wondering if you can give us more details about the changes, the pathophysiological changes that in obese animals can affect this anesthetic protocol.
So we have here this article, which is quite interesting to talk about the perioperative physiology and pharmacology of the obese small animal patients, which talks about all these pathophysiological changes. So in summary, the changes due to obesity higher cardiac output to perfuse this tissue. This causes a decrease in cardiac reserve, so it will predispose to heart failure or heart problems. There is also infiltration of adipocytes into the cardiac tissue that may reduce the ventricular performance and may predispose patients to the onset of cardiac arrhythmias. These cardiac changes, interestingly, are reversible in dogs once they have lost the adipose tissue. Therefore, if we manage the patient to get to the ideal weight, or at least reduce the obesity to just overweight patient, we may help these cardiac issues, and they are reversible, which is really interesting. Talking about the respiratory changes, which is also one of the important systems for anesthesia, the abdominal organomegaly caused by basically increased fat tissue infiltration in the abdomen causes the diaphragm to be cranially displaced, therefore causing a compression of the lungs. There will be also thoracic fat accumulation in basically in the chest wall, and these patients will have a hard time to ventilate. Therefore, all this fat accumulation and abdominal accumulation, it will increase it will make harder to ventilate, and it will increase the work of breathing. There will also be increased pulmonary blood volume because we have seen that we need higher cardiac output. If we need higher cardiac output, this cardiac output will also go to the pulmonary blood flow because we have increased circulating volume to be able to perfuse all the tissues. All these changes will make a decrease in the functional residual capacity of the lungs. That will be basically decreasing the oxygen reserve of the patient, and we will have an increased oxygen consumption to be able to perfuse all these tissues, and an increased CO2 production. Therefore, these patients will be less tolerant to periods of apnea. They will desaturate quicker after administration of drugs that cause respiratory depression. And all the anesthetics, basically, the general anesthetics, meaning the induction agents, will obviously cause respiratory depression. In the bronchial alveolar part of the lung, we will also see a bronchial and alveolar collapse, making alterations in the ventilation perfusion ratio in the lung fields, compression atelectasis, just of the weight of the thorax on top of these lungs, and also the diaphragm. And if we sum everything to the dorsal recumbency of the patient, we'll accentuate the decline on the functional residual capacity and compromise the patient ventilation. So if we have an obese patient placed on its back to do a surgery, and for example, abdominal surgery, probably this patient won't be able to breathe properly and we will have to ventilate him. Additionally, anatomical alterations of the basically accumulation of fat everywhere will complicate a little bit things for the anesthetist. First of all, we will have complication on the IV catheterization, and that's why I put a picture of this dog that is quite body condition score of 5 out of 5, and also has really short legs. So this is going to make it really difficult for us to place the IV line. There will also be a difficult intubation due to the increased fat on the oropharyngeal and cervical area. So really, really important to pre-oxygenate these patients before induction, especially if they are brachycephalic, obese. And this is all the clinical picture that you can imagine that you will have an obese brachycephalic dog with really bad veins, and we have to anesthetize him for something. So pre-oxygenate this patient very well. There will be some loss of anatomical landmarks that will complicate the locoregional anesthetic techniques, for example, the epidural, basically because when we are trying to do an epidural, normally clinically, we will locate by palpating the landmarks, and this will be a little bit complicated. So the anatomical alteration affecting anesthesia, and speaking about local anesthesia and locoregional techniques, especially in the epidural, we need to calculate the dose of local anesthetics for the ideal body weight, because the epidural space is the same, although the patient weighs double, meaning that we shouldn't be giving too much local anesthetic to, for example, a cat. So we have always to check the local anesthetic dose to avoid toxicity, especially in cats. And also in humans, it's reported that the reduction of the volume of the local anesthetic in the epidural space is recommended due to the adipose tissue accumulation also in the epidural space and the engorgement of the epidural vessels. Therefore, if we are doing an epidural, we need to calculate the dose of the local anesthetic based on the ideal body weight of my patient. In dogs, we have some consequences of this obesity. So if we have obese patients, they are more prone to have orthopedic problems, congestive heart failure, hypertension, reduced tolerance to ambient heat, tracheal collapse, dyspnea, pancreatitis, urinary diseases, neoplasia, dystocia, and non-allergic dermatological problems. These are all the consequences, or basically, yes, secondary diseases to obesity in dogs.
Many thanks, Alejandra. So we have been seeing how obesity can affect the anesthetic protocol and other diseases that can affect this protocol in obese dogs. But I don't know if you can share with us which other diseases can affect the protocol in obese cats.
So speaking about cats, we have also, of course, obesity in cats, and this is also quite high. So the consequences or the other problems that we can get associated with obesity in cats is again, orthopedic problems, osteoarthritis, hepatic lipidosis. If we have a really obese cat that is not eating during a few days, then we get quite quickly hepatic lipidosis. We can find diabetes type 2 in cats, and also hypertension and myocardial hypoxia. So obesity in cats is also a quite common problem.
Okay, so my next question is that, well, taking into account obesity, do we have to think about reducing the dose of anesthetics in this kind of animals, or it's not needed?
So we have spoken about the epidural, reducing the dose, but for what about systemic analgesic and anesthetic drugs? So the drug doses and the drug adjustment of this dose will depend on primarily two things. First, the route of administration that we are going to give to the patient, and the type of drug that we are going to give. So the route of administration, we can think about subcutaneous, intramuscular, or IV drugs, centering on anesthetics. And then the type of drug, there are some anesthetics that are more water soluble, and some others are basically lipid solubles. So if we speak about subcutaneous drug dose, if you think in an obese patient, we will have a lot of subcutaneous tissue, but this perfusion of this subcutaneous adipose tissue is not great. Therefore, if we inject a drug, an anesthetic drug or sedative drug, by subcutaneous route, the absorption of this drug will be really slow. So it's not the preferred route of administration for us, for anesthesia. And we also have to take into account the injection site and the length of the needle, because sometimes we are supposed to give an IM dose, but we end up giving it subcutaneously because of too much fat accumulation. Therefore, the length of the needle is important when we have an obese patient, especially if it's a large size patient. The subcutaneous fat tissue also will act as a reservoir. So when we are doing an anesthetic, administering IV drugs, inhalational drugs, etc., we will get accumulation of these drugs that we are giving to our patient into the subcutaneous tissue, into the fat tissue, making like a reservoir. So we will have this accumulation in these patients, and this will delay the elimination of these drugs and prolong the anesthetic recovery. So we have to take into account that the fat also in lipid-soluble drugs will act as a reservoir. So probably my patient will take more time to sedate, for example, and more time to recover from the sedation, for example. When we are speaking about intramuscular drug dose, the intramuscular administration normally is on body weight based dosing. Basically, if I am going to pre-med a cat or a dog that is overweight or obese, I can probably not reduce the dose for IM administration because probably I want them to sedate quickly, and sometimes, as I said, I'm thinking I am injecting into the IM, into the muscle, but actually I'm injecting probably subcutaneous tissue. So for the sedative drugs, when I am doing an IM drug dose, I could just dose the patient into the actual weight. Additionally, for IM drug administration, the drugs need to be hydrosoluble, otherwise they won't get absorbed from the muscle. So this is an important factor regarding the drug dose adjustments. Examples of drugs that I can just administer IM to my patient without having to adjust to the actual weight to the ideal weight, just given to the actual weight, is alpha-2 agonists, opioids, ACP, midazolam, ketamine, basically the pre-med drugs. If I want to give them IM, I could just administer the dose as the weight. My Labrador weighs 35 kilos. He should probably weigh 30, but if I am going to pre-med IM, I could just give him for 35 kilos the pre-med. Other thing is if I am going to, this Labrador that I have pre-medded for 35 kilos, now I'm going to induce this patient using an IV drug. So in IV administration, we have to take into account that this dose should be calculated according to the patient's lean weight or ideal weight. Because of the increased volume of distribution and increased drug elimination half-life that this patient has, basically completely the opposite situation as we had in cachectic patients. The clearance is increased by the increased cardiac output. And anesthetic drugs for IV administration are normally also lipophilic, for example, induction agents. And we have this interesting article that speaks about the effect of body condition on propofol requirement in dogs. I'm speaking about propofol because it's the kind of the drug that we normally use more for induction. So for IV propofol administration, we need to think that this patient, this Labrador that we had, 35 kilos, he should weigh 30. So when I am calculating my dose of propofol, I will do it for the ideal weight, for the 30 kilos. So if I have to estimate my ideal weight for my patient, how can I do it? If I know the breed and more or less the size of my patient, I can estimate it. Otherwise, if I don't know because it's a crossbreed and I'm not sure how much my patient should weigh, I could use the body mass index. And this we can basically calculate it with this table that you have here. Is from the Anesthesia in Cats and Dogs with Concomitant Diseases from that book. And you have there in the right-hand side the body weight in kilos, the body surface, and we can basically adjust the dose of propofol or alfaxolone or any induction agent to the body surface area. Here you have it. What is this based on? In this study that speaks about the comparative study of anesthesia induction in obese dogs using propofol dosages based on lean body weight or total body weight. And again, we should adjust our doses when we are giving an when we are giving an IV dose.
Thanks, Alejandra. So we have been seeing the main considerations for obesity, cachexia, and also how to calculate the doses and the route of administration. So let's move now to the monitoring of these animals, how we can or what we have to consider when we are monitoring an obese patient.
Okay, so there are potential difficulties that we will have during anesthesia with these patients, these obese patients. First, we will have sometimes difficulty palpating pulses, especially femoral pulses. We will also see during anesthesia that they have an increased heart rate due to the increased cardiac work and increased cardiac output. So we will normally see tachycardia in these patients. They will have a shallow respiratory pattern and an increased respiratory rate because of the respiratory depression effects of anesthesia, but also the changes, the physiopathological changes that we have already spoken about in these patients. The non-invasive blood pressure monitoring may be a bit difficult because we have an increased subcutaneous fat accumulation, and the measurement accuracy of these blood pressure cuffs may be even more inaccurate than what they normally are. And temperature regulation. So important to check the temperature in an obese patient because sometimes we see hyperthermia. So check the temperature every 15 minutes at least in an obese patient.
So now, following this, the treat of monitoring, can you share with us how to adapt the mechanical ventilation to these obese patients? What is your opinion or your experience?
Mm-hmm. So as we have spoken, these patients will have difficulties breathing. So how should we adjust the mechanical ventilation if we are going to mechanically ventilate these patients? So we should be ready to ventilate them and not be scared about that, because these patients have this restrictive pulmonary disease with a reduction in the tidal volume, the shallow breathing, increased respiratory rate, especially in supine position or supine position when we put them on their back. They will have increased respiratory work because of the airway fat accumulation. Also, we will have the compression atelectasis in dependent areas, and this will be much more important, again, when we position them on their back. So one thing that we can do to try to help them is to put the table, like you see here in this picture. We can position the table in anti-Trendelenburg position with the head higher than the rest of the body. That will make the abdominal viscera basically by gravity dropping a little bit and improving the mobility of the diaphragm. The diaphragm is the most important muscle for breathing during anesthesia. Obviously, the intercostal muscles as well, but the diaphragm mobility is really important for them to be able to ventilate properly. So the lower respiratory system compliance that we see are due to abdominal organomegaly, accumulation of adipose tissue in the chest and abdomen, and then the atelectasis that we have. And there, here in the image, in the right-hand side, you have a CT of a dog placed on its back, and the white areas here at the bottom are basically atelectasis. This is a chest of a dog, fat dog. You can see here a little bit of fat. These white parts of the lung are atelectasis. They should all be like here, like black, because the lung should contain air. But in this patient, on its back, you can see that there are compression atelectasis on basically both lungs. So all these problems breathing will lead to hypoventilation, which is the main concern. We should monitor the SpO2, the saturation of peripheral oxygen of hemoglobin, the end-tidal CO2, and if we have, it will be nice to have spirometry with the tidal volume, compliance, etc., etc. Here in the video, I can show you a patient, a quite obese patient placed on his back, which he was hypoventilating with a shallow breathing, rebreathing quite a lot due to the increased respiratory rate, but the shallow breathing. So you see his heart rate it was a dog, so it was a little bit high. Saturation was okay because we were supplementing with oxygen, but the end-tidal CO2 is 45 with a respiratory rate of around 50, and he's rebreathing 15 millimeters of mercury, which is quite high. The blood pressure, thankfully, was okay, or even a little bit hypertensive. So this hypoventilation, we need to treat this patient. We shouldn't leave it like this. When are we starting mechanical ventilation? So normally, in cases of severe hypoventilation, when the end-tidal CO2 is higher than 60 millimeters of mercury, we should start mechanical ventilation. So how are we going to ventilate? First, we need to calculate the tidal volume of my patient based on the ideal weight to avoid over distension of the lungs. So the tidal volume, if you don't remember, I'll tell you, is around 10 mils per kilo, approximately. So if we go back to our example of the 35 kilo obese Labrador, but we thought his ideal weight should be 30, his tidal volume will be 30 times 10, so 300 mils. And that's what I will put on my ventilator for the tidal volume if I am ventilating by volume. We can do during anesthesia an alveolar recruitment maneuver, because we have seen in the previous slide that we had some atelectasis. So the alveolar recruitment maneuvers will open up these atelectasis zones of the lung that are compressed. And then we should apply positive end expiratory pressure, or PEEP, optimized for each patient. Here in the image that is from this article, Canfram et al. In 2012, you can see a diagram illustrating alveolar recruitment maneuver step by step and checking the optimal PEEP optimized for that patient. So in this alveolar recruitment maneuver, we are going to go to pressure mode, give five breaths to my patient, increasing progressively the PEEP and the peak inspiratory pressure until we get to the opening pressure, and then basically reducing again both until I get the closing pressure and the optimal PEEP for my patient. Otherwise, if you think this is too complicated, too much for you, you can just give one maximum breath manually, alveolar recruitment maneuver, one breath to up to 30 centimeters of water, maintained during 10 seconds, and that will be one-time alveolar recruitment maneuver, and then you should put some PEEP on your patient and keep ventilating him with this PEEP to avoid further atelectasis. This maneuver could be done if your compliance goes down, or if you don't have spirometry and you feel your patient is getting again atelectasis, your SpO2 is decreasing, you could repeat it every hour, every 2 hours, depending on how the anesthetic goes. Always checking first the blood pressure is correct before doing an alveolar recruitment maneuver, because they have an impact on your cardiovascular system.
Thanks, Alejandra. So we have been seeing all the pre-anesthetic and anesthetic considerations, and I think that now it's important to move to the last part, because it's also quite important. I mean, the recovery of these animals. So which are the considerations, or which tips can you give us for the recovery of these animals?
So as we said, recovery can be a little of a challenge in obese patients. As you normally know, critical period in veterinary anesthesia is the recovery time, and accidents or mortality during anesthesia can happen at some point, but normally happen more often during recovery. So this period is really, really important. So in obese patients, we have normally a prolonged recovery due to the accumulation of drugs in adipose tissue, as we spoke about before. We should pad properly and have a nice bed for these patients to prevent pressure sores, especially if they are going to be lying down for a long period of time. For example, a neuro patient or orthopedic patient that they can't move really well. So we should prevent these pressure sores. Drug metabolism and elimination, as well as the respiratory depressant effects of anesthesia, will increase the recovery time. And prone position to facilitate ventilation and respiratory effort should be encouraged. So basically, we should always give them oxygen, put them in sterile recumbency, and stay with them until they are fully recovered, and this can take a little longer in these patients. This oxygen supplementation can be given by different methods. You have some pictures here, basically just a face mask, Buster Polar adapted to give them oxygen, or like in this paper, non-invasive continuous positive airway pressure delivered using a pediatric helmet in dogs recovering from general anesthesia. This worked very well, but you have to be with them all the time, because this helmet, you cannot leave the dog alone with this placed. So it's really useful, especially in brachycephalic dogs, but needs monitoring. And of course, one of the main important monitors that we will use in the recovery period, it will be a pulse oximeter. So we will always supplement these patients with oxygen by any method and monitor the SpO2 until basically they are up and about. So as basically conclusions and recommendations in cachectic and obese patients, well, especially in obese patients, we should use short-acting drugs with low accumulation in fat, but it's difficult, as we spoke about. Mainly all anesthetics are quite lipophilic. Or if we can administer drugs that have an antagonist, then that should be ideal because we can basically antagonize the effects of our anesthetic drugs and the recovery will be quicker. Adjust the drug doses when we are giving drugs intravenously. Sedation, always check your patient after sedation or during sedation for the respiratory depression and or hypoxia, so always supplement them with oxygen as well as pre-oxygenate them before induction because they will desaturate quite quickly. And try to use local regional anesthesia if you can to reduce the administration of systemic drugs, although it might be a little bit more difficult due to the loss of anatomic landmarks. Use mechanical ventilation in obese patients and recruitment maneuvers on PEEP. I don't always mechanically ventilate them. Sometimes I try to keep them spontaneously breathing, and then if I see that they can't, obviously, then I will start mechanical ventilation. Other people will just start them over mechanical ventilation straight away, but up to you, just check your patient and adapt of the needs of your patient. We can use the inverse Trendelenburg position or anti-trend position. Monitor very well blood pressure, heart rate, and body temperature, and recovery. Observe the patient's ventilation capacity until they are fully conscious, especially if they are brachycephalic. And thank you very much for your attention.
Thanks, Alejandra. So we are at the end. We have been receiving some questions, so we will stop for 30 seconds and we will come back to answer all these questions. Many thanks.
Good, thank you.
Okay, Alejandra. So, well, I will start with the first one. The first question is that, okay, we have been talking that we have maybe we have to adjust some anesthetic drugs in obese animals, but do we have to reduce other drugs or not?
Okay, so all the drugs that we may administer perioperatively, like antibiotics or other drugs, again, it will depend a little bit on the lipophilic or hydrophilic drug that we are using. For example, if we are speaking about drugs for treating cancer patients, like chemotherapy, that will definitely be adjusted to the body mass index of our patient. So depends on my answer will be depends on the drug that you are giving. If you are giving an IV drug, normally, yes, we will have to adapt and adjust to the ideal body weight. And if we are giving, for example, a chemotherapy or other type of drug, then definitely check your body mass index and adjust to those.
Thanks. So we move to the second question. The second one is that in the case of the animals with cachexia, we have been talking that it's important to take into account the blood pressure. But I don't know if you can give us more details about other considerations when we are monitoring these animals that are cachectic.
The cachectic patients, okay. So basically, regarding the blood pressure, we spoke about the cuff when we are using non-invasive blood pressure. So it's really important that the cuff is adjusted to the limb, to the diameter of the limb, and so if you have a cachectic patient and they are really thin, you should probably check that your cuff is adjusted properly and that your breathings are actually meaningful and they make sense. Otherwise, sometimes depending on the surgery that we are doing to our patient, if we are doing a really invasive surgery, normally we recommend to place an IV line into the artery and check the blood pressure invasively. If we are going to go to non-invasive methods, we could use Doppler, we could use oscillometric. And also one thing that I didn't say that may be important is check the blood pressure before anesthesia to have a baseline measurement. I didn't say that in obese and cachectic, but check just in case they are hypertensive to start with, which it will be a baseline measurement, and then we know more or less the range of pressure they are normal for our patient, and then go for it. One important thing, talking about blood pressure during anesthesia, is not only the numbers, it's the trends. So if your blood pressure is going down slowly during anesthetic, this is important, and we should always try to keep it stable. So if it's going down or going up, just check what are the reasons for your patient to be hypotensive or hypertensive, and try to work out what's going on and treat it.
Thanks, Alejandra, for the details. So, well, we have here another question. That is that during the presentation we said that cachectic animals usually they tend to have hyperbilinemia. So for that reason, should we avoid any kind of drug, or what is your opinion?
So when we have hypoalbuminemia, basically what we will have is a higher free drug in our system, and they will probably make much more profound effect when we are giving a dose to our patients. So really, we should try to adjust. For example, I will give you an example. If we have propofol versus alfaxalone, propofol is 99% protein binding, and main protein that we will bind to is albumin. So, for example, alfaxalone is only 70% protein binding. So if your proteins are low, you should probably use alfaxalone that is normally not that much binding to the albumin, therefore probably won't have that much peak of effect that you are expecting when you have hypoalbuminemia. So it's not that you have to avoid propofol, but probably if you can choose, you should choose a drug that is not that protein binding drug.
Okay, thanks. And let's move to the last question. The last question is about obese animals. And if you recommend ventilation by volume or pressure, what's your choice?
Okay, that's a really, really good question. So basically, when we are in anesthesia and we are going to ventilate a patient, we should choose if we are going to ventilate by volume or by pressure. We have spoken about how should we adjust the tidal volume in a volume control ventilator. I normally like to ventilate them by volume because I can adjust to their ideal weight, but not always will be able to work in a volume mode. Depends on what you have. So not all ventilators will ventilate all patients, all the range of patients that we have, because we can have an obese Chihuahua that should weigh 2 kilos but weighs 4, for example. But also we will have to ventilate a 70 kilo obese Bernese mountain dog. Therefore, sometimes we don't have a ventilator that can deliver the volume for all the range of patients that we are going to work with. So sometimes, although I like to work by volume, sometimes I will have to work in the pressure mode control, especially for the smaller patients, for the small size patients. The only thing that you need to consider when you are ventilating by pressure is that it's quite safe, because it won't damage, it won't get volute trauma, because obviously the pressure is controlled and it will get to that pressure and stop, and it won't damage your lung, but it can probably hypoventilate them if you are not checking properly, because it will get to the pressure. It doesn't matter the volume, the volume will be the volume needed until getting to that pressure. So if someone, basically a surgeon, or you change the body position of your patient because you're doing CT and then you're doing ultrasound, or someone in surgery steps on the patient. So basically you could have hypoventilation with a pressure mode. That's the only side effect, or the only problem that we have with the pressure control. However, with the volume control, if we don't adjust properly the volume for our patients, we could damage the lungs because we are giving too much volume. So we could get bone trauma.
So many thanks. We have to stop the session here because we don't have more time. So, well, Alejandra, thanks for sharing your time with us. I hope you have enjoyed this session. It's the last one, let's say, before summer, but we will come back on September with more webinars. So we will be waiting for you then. And well, enjoy your holidays and see you soon. Many thanks.
See you soon, and thank you very much.